Welcome to the Site Selection Strategies conference call. My name is John, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Ms. Liz Buttrey. Ms. Buttrey, you may begin.
Thanks. Welcome, everyone. Again, this is Liz Buttrey. I want to take a moment to thank Drs. Jennifer Potter and Shauna Rothwell for presenting for us today. We are looking for your feedback, questions, and dialogue. So if you have a question at any time, press *1 and the operator will open up your phone line to present your question or discussion item to the presenters. We also are going to utilize the Q&A feature at the top of the screen, so feel welcome to input your questions there if you so choose to do so. With that, I will go ahead and turn things over to you, Shauna.
Good afternoon, everyone. So first I wanted to talk about the discussion outline. First we will just discuss establishing site collection criteria, as well as coordinating site selection efforts and optional recommendations about the process. So the important step is when establishing your site selection criteria is starting it with the end in mind. Why are you crossing this road? It's important to understand what your endpoints are, what your goals are. That being said, the average cost of clinical trials has risen in the last few years. Potential contributing factors to these increase in costs could be, one, the lack of a completion plan, as mentioned before, as well as the decreasing supply of the suitability of available sites, and study complexity. As studies become more complex and have more assessment burden, that is more cost. And the sites that are productive, there's an overextension of those. And you also have underperforming sites. So I'll turn it over to Jen.
Thanks, Shauna. Liz, I don't recall, I was a little bit distracted. I don't know if you mentioned that we can people should feel free to interrupt with questions.
Oh, absolutely. At any time, they can press *1 and present their question to you.
Because obviously I was just looking at the names of everyone who's on the call, and we've got people with a lot of experience on here. So certainly I don't think that we are the be-all and end-all of site selection. And
no, feedback would be great. Any kind of dialogue would be fantastic. Everybody is welcome to press *1. Or you can use the Q&A feature. It just depends on their comfort level.
Great.
And pardon the interruption. This is the operator. We do have a question already.
All right, great.
Okay, it's from R. Zeppel, MD. Please go ahead. And pardon me, R. Zeppel, your line is now open. If your phone is on mute, please unmute it.
Should we just go ahead and if...
Yeah, let's take him in just a minute.
I'm sorry, Liz, did you say give him a minute or not?
We'll catch up with him later.
Okay.
Go ahead.
Great. So I think just a little bit of a background on why I'm particularly interested in this topic and was so appreciative of Emma asking me is that I think the issue of site selection kind of does not always get the attention that it could, although certainly I think we in the CTN have been very diligent and aggressive in developing and maturing how we do that. But it got me very interested, and I think Liz actually put this definition into the slide, which I like because I'd never actually looked up the definition of selection, but carefully choosing someone or something as being the best or most suitable, which in principle sounds really terrific, but how you actually execute that is a whole other kettle of fish, and I think it's really open to a lot of interpretation. So just some background on why this, I think, has become important in the CTN. As an infrastructure and as an organization, I think things like this naturally rise to the surface because we have the luxury of time and a lot of really intelligent people and productive people to think about it. And where I started to think about it in the context of the CTN is a number of years ago, and there's some folks on the phone that I know may remember this as well, but it was at a steering committee meeting where the esteemed Dennis Donovan was talking about site selection, and we were concerned about how to deal with recruitment. And we were beginning to have conversations about, well, maybe we need to be more formal or systematic or standardized in the way that we did site selection. And my sense of it was sort of, hey, who wants to be in the study? Do you think you've got a lot of people? That's great, let's do it. And I think that makes sense for a lot of reasons, but when we started to realize that we needed to maximize our efficiencies, we really tried to start to button that up. And it's changed a lot over time, and so some of what we're saying here may be new and some of it may be things that have evolved over time, but I just wanted to give some context to it because that's almost 10 years ago now. But I think it really has done a nice job. But underlying that is an assumption that doing what we do in the CTN is going to improve trial performance, because at the end of the day, it's not about selecting sites, it's about doing the best trials to get the best answers to the questions that we're doing. And we're learning as we go, so it's an evolving process. Do you want to do next slide, Liz? So just, there's a lot of things that we could add to this list, and if we had time, I'm sure everybody could add to it and nuance it. But from my perspective, at the end of the day, for me, site selection impacts, as I've already said, recruitment and retention of trial participants. And not just that, but it's recruitment and retention in the context of a timeline and how much money and resources we have to devote to a trial, because if we overdo it on one, we may not have the funds for another. So we want to be efficient and productive. So at the end of the day, it's about an effective, high-quality study implementation, and that's where I think that we got to be thinking about ourselves as a potential site and as lead investigators in how we design and choose our study sites so that we can all benefit from that. So we came up with this concept of what we think of it, and at the core of it, it really is driven by the protocol design. The protocol shouldn't be sacrificed so that we can get good sites. But at the same time, we should be very diligent about making a protocol. Let me back up because that didn't make sense. So when we come up with a protocol, there are two ways I can think about it as someone who might be designing a study. We can think about the questions that we want to answer, and then we think about the questions that we can answer. And I think this is the same for site selection as well. So we want to pay attention to, when we're designing a study, do we have a design that's feasible and reasonable to implement? And I can hear that a lot of times in the CTN, particularly for the folks that are in the trenches collecting the data. When there's a study that they're concerned, do we really have this study population? Can we recruit these people? But at the same time, the converse is true too, that we have to design the best study to answer the question that we have. So I hope that made sense. But feeding out of that are a lot of things that I think are important factors in site selection. So it's the study population needed. Do we have them at the places where we have sites? And even if we have them, do we know how to get to them? It's the institutional and node support. So, to use my node now, the Texas node, it's not just does Dr. Trivedi in Dallas have the support for me as a potential site, but does my institution, does my organization have the support? Is it really something that they've bought into as a group? And presumably at all of our CTPs, we're at the point where our institutions have bought in. But, that's a process, particularly for certain types of studies. So an example would be a placebo-controlled trial for a study drug might be more appealing to some institutions than others, or a medication trial versus a behavioral trial. And something else that we'll go into, I'm realizing I'm kind of jumping ahead with my slides here, so I'm going to try and be a little more efficient in doing this overview. But as you'll see as we go through it, there's also issues related to oversight and staffing, and site resources and limitations, and then general site capabilities. And no one of these things necessarily trumps another. So it becomes really a kind of a balancing act about how we value each of these things and how we give them weight in terms of the site selection process, both locally thinking about it from the perspective of the potential site and also as the investigative team that's going to be ultimately selecting the sites.
So before I begin this slide, I just wanted to circle back to the individual that may have had a question at the beginning. Is that person available? Okay.
Perhaps it was a mistake.
Okay. So first step in establishing your criteria, and this is more for the lead team. You want to evaluate your investigator. For example, what qualifications, proximity to the site, affiliations, and I like to think of these items as your non-negotiable items, things that you just can't possibly see your study surviving without. Also, your research staff. What types of staff are needed? Do you need licensed counselors? Do you need a phlebotomist? If a phlebotomist is not needed, what types of certifications do you need for individuals to have or obtain to perform certain duties per protocol? Also, the research site. Are there certain accessory facilities needed, such as a local lab or a pharmacy? A lot of times CTPs are limited in the ability to obtain a local lab or even have a pharmacy. So these are types of things that you really want to answer on your survey or see if it's possible. And one of the things that I love about the protocol is that there's a time and events table in the protocol. And it's a way of looking at the system as a whole, as far as looking at the different visits from baseline all the way up to follow-up. When you look at this table, you'll understand exactly what types of the schema of the study as well as the steps and individuals that are needed for each process.
I also this is Jennifer again. Just one other side thing. I have a tendency to talk really quickly, so I'm more than happy to be interrupted and told that I need to slow down, particularly when I have a cold. So if I am going too fast, please feel free to shoot me an email or jump in on the line. Yes, ma'am.
We'll keep you in check.
Okay, thanks, Liz. Excuse me. So we've already started talking about, I think, some of the nuances to this and this sort of process of trying to figure out what the best sites can be and the sites that you have to select from. So a couple more things from the lead team perspective, and Rashawn has already alluded to this idea of what are the non-negotiables. But there are other things to think about as well in terms of the short-term interest and the long-term interest of the study. And you know, I might jump back and say some of this has come from a paper that a group of us wrote, and it was in the recent special issue on the CTN on lessons learned that was in the American Journal of Drug and Alcohol Abuse. And I think there's going to be a link to that paper at the end. But one of the things that was interesting in writing that was, you know, from the perspective of the lead team, one of the things that I was doing was saying, I want the best sites possible. I want the sites with a lot of experience. I want the sites that I know have a track record that really dazzle me with their experience. And the other thing that came back, and this is a long-term interest, was some feedback that my co-authors reminded me of, is that, you know, in the CTN, one of the things we also want to do, and that we've done a very good job of, is bringing new sites online. And sites that wouldn't necessarily have done research were it not for the CTN, but that now are doing it and doing a wonderful job, and not just doing CTN research, they've really expanded beyond that. And so I think that's another example of a short-term interest versus a long-term interest, both for a specific study as well as the CTN as an organization, because as we gain more experienced sites, we have more flexibility for the next study and more potential sites with experience and all of that. So it's just something that I wanted to mention, because there may be folks on the line that may be at a site that don't have as much experience as some of the sites that have done a lot of studies and really have a track record of doing it. But again, I think it's prioritizing protocol needs. I don't need to hit this too hard, I think, but what are the staffing needs, the facility, and the regulatory needs? An example, just going back to something that Shauna said about pharmacy, in a trial that we did when I was at the Northern New England node, which is no more, now it's the New England node, we had a site in a terrific area, and it was an area that really had a strong need for a prescription opiate abuse study, which is what this particular study was, because of the area of the country and where we saw the epidemic of prescription drug abuse. And it turned out they didn't have a pharmacy, and they had very little experience, but what they had was a lot of really, really good people in their node who had done studies before and who could support that study. And just even thinking of the pharmacy, initially that study started with a local pharmacy in the town. It was a relatively rural area. So even when there's things that you need to have, there may be creative ways with a good node and good support from your node to figure out a way to make it happen. And it ended up being a terrific and fabulous site. And at the time and events table, so we can go on from this. I think this is somewhat redundant. So again, going back to that little wheel that we saw there about the different things that after the protocol drive site selection, was one of the things is population. And I really can't emphasize this enough. The availability of the study population is paramount. And one of the things that I think can happen is we see a lot of different people with a lot of difficulties walk through the doors of our clinics and our programs. And the first thought, and I do this myself, is, oh, we've got oodles of those people. We've got lots of those folks. Certainly we can recruit at, 30 or 50 or 100, whatever the number is. But it's not that easy, and I think many of us here would know situations where we thought we had the study population to sample from, and it really sort of evaporated when we went to actually get them through the door within the timeline that we had. So this is just, at the end of the day, so important to really do our homework, both nationally at the lead node level and at the local site level, to really make sure that we can do, to the best of our ability, an exhaustive evaluation of whether we can do that. And that's important for a lot of reasons. And, a lot of this we've already said, but it's a high cost for recruitment. Advertising is expensive. Some of the media markets are extraordinarily expensive to advertise. At the same time, it takes a lot of effort from staff. So it's not just financial cost, it's cost to your staff, their enthusiasm for research, the timeline. It impacts not just your site, but other sites that are trying to get this study done. It impacts the next study that's in the pipeline that we'd like to be able to fund. So across the board, it just has a real impact. So that's why we want to make sure that we do that, and it's why so much of site selection now in the CTN, I think, is emphasizes this issue. At the same time, lead nodes have a responsibility, I think, and the designers, investigators of studies, to really think about feasibility from the beginning. The question is always, at the end of the day, important, but we need to think about feasibility and whether we can actually get these folks. And, I've seen numerous examples in the studies that are either just recently come online or are now coming online, where there's a lot of attention that was paid, even in the development of the protocol, to making sure that it was a population that we could actually get in the clinics, that these were real people that actually existed and we had enough of them to get them. Next slide. Something else, and this is sort of sitting here a little bit on its own, but we wanted to mention, is one of the other things to think about with site selection is, if you've been successful or if you have a site that's done a terrific job on a previous study, that's important, but it's not the only thing. And I remember why this is here. The reason that we put this in population was just anecdotally. There was several years ago a site that had done a fabulous job on other studies. I can think of several of them, and a couple of these were on POTS. And it was clear this was a site that could perform, that could do what they needed to do, they could get a study done. But at the end of the day, with certain study populations, it can be difficult to get them, even for the terrific sites. And that might be because of the epidemiology and geography of the substance problem or accessibility. So, we, for example, in POTS had sites that were terrific. They were recruiting. They were working really hard. But at the end of the day, the population that they had to look at was the heroin population. And so that was a place where we were excluding a lot of folks because there was just too much heroin use, and we really needed an exclusively prescription opioid population. So on the face of it, no one would ever think that this site would have trouble, because they didn't truly have trouble, but they just didn't have access to the study population. And we wanted to mention that, because it doesn't mean the next time they wouldn't be the terrific site to do the next study. It was just a population fit for them. Okay, and I think, Shauna, you're back on.
So for a lead team, when examining a site's capabilities, as you can hear, recruitment is a very, very integral tool to site selection. The site's capability to do this. So you want to look at the CTP's existing patient population. In so doing, what are their media advertising efforts? How do they actually get people in the door? How could they possibly advertise your study to potential participants? Are they creative? Do they use community recruitment sources? How are these recruitment sources obtaining these participants? Do they have a copy of your inclusion-exclusion criteria? These are all questions that can be asked. In addition, how are they able to locate and access potential participants and participants after they are a part of your study as far as follow-up rate? Is the site able to adhere to timelines and study expectations? I'll talk about this in a little bit, but if there's a hitch in a timeline, it not only impacts when your study starts, it impacts cost, as we talked about previously. It also impacts efficiency of the study. In regards to regulatory compliance, Can this site provide appropriate documentation of their regulatory documents? DEA registration, are they in compliance with those? Do they need to obtain DEA registration? What is the timeline associated with that, and will that impact the study? These are all types of questions that a lead team could potentially ask a site when examining their capabilities. Also looking at sites' resources and limitations. Pharmacy, one of the biggest things lately is that you want to make sure that your CTP or research site knows their DEA regulations in regards to the pharmacy. For example, when dealing with a Schedule III medication, local regulations can impact who can dispense it, how is it stored. I think it's important for lead teams to impress upon sites to understand their local regulations and be prepared to discuss them in the survey and on the call. Also, local laboratories, your availability of a local laboratory, your timeline for sending and also obtaining results, and also obtaining the appropriate licenses such as CLIA and CAPS that are associated with the laboratory. Your number of IRBs that are involved. The more IRBs that are involved, that means more timelines. That could also mean if there's a delay in submission or a delay in response, that can impact the overall timeline for START. Some things for the lead team to also consider are different site structures. For example, VA sites versus nonprofit sites and government sites may have limitations in their population. So it's very, very important to understand site structure and how that site structure can impact your study.
Shauna, I know we've got to watch the time, but I just wanted to throw in there a couple things. I'm just thinking that if there are some of the folks on here who are relatively new or maybe haven't done a study that involved a pharmacy before but are at a site that would be interested in that, I think one of the things that hopefully you might get out of this presentation are sort of talking points for you to take back to your node and say, you know, we've never really thought about our pharmacy capacity or some of the other laboratory issues, because when you're not looking to be a site is when you have the luxury of the time to do this. And so hopefully all of you have had in your node discussions about this, but if you haven't, this would be a good opportunity to kind of take back a list of these things and think about it. The other place that I'm thinking about that is we have in the CURB trial, and I can't even remember the number, but in the CURB trial we're one of them here in San Antonio, 2 VA sites, and one of the things that we've done has worked collaboratively with the Atlanta VA site to talk about some of the issues that are coming up at the VA. And so that's kind of knowledge that we have that we probably should try and hold on to so that if another VA site was interested in coming online, we could talk about some of the issues about dealing with the VA regulatory issues that we've run into and some of the policies and procedures. So I just wanted to throw that out because sometimes I worry that we reinvent the wheel across studies because we don't always know what's going on across some of the trials because we're all so busy. So what I am supposed to be talking about is site resources. Oh, no, I'm supposed to be talking about oversight and staffing. And so one of the things that I thought I have learned is so critical in site selection is that as you're going through the site selection process, either as a candidate site or as the lead team, is the dialogue that goes on around that is so critical. So as the lead team, this is the first chance that potential sites are going to have to learn about you, to learn how you interact with your sites, to how you treat sites, how you ask for information, how you provide information, and how you set the stage for potential sites. And I think that this is a building of a relationship. And I would argue that the relationship starts in these early communications because it just starts to get a sense of everyone as they get to know each other. And it's not always the case that we've worked all collaboratively before. And I think it's essential for the research collaboration as the study goes on. And I think a big piece of this is that there is this open dialogue about expectations, challenges, and resources. I mean, one of the refreshing things I hear from a lead node sometimes is the thing we're worried about is recruitment, or the thing we're really wondering about is how we're going to keep these people in trial, because as a potential site, I'm hearing, well, these are the things that they are concerned about, and they're the ones who designed the study, so I should really focus on those things, both to demonstrate my capacity to do it or to really evaluate whether it's possible for me to do it. And I think at the end of the day, the sites really need to have that frank evaluation of whether or not they can pull it off. We have a couple sites here in San Antonio, and there are some studies that I think are really challenging, and we need to sit down when I'm working with the sites down here that we really try to do a really honest assessment. And they're eager and want to be part of a study, and I really want them to be part of a study because I want the CTN to be more involved in San Antonio, Texas. But at the same time, we have to sort of be the ones to pull the trigger on whether we can actually do this. And so we're going to later on talk about some concrete ways to do that, but I think that that's another important piece. So as you can see, I'm kind of toggling back and forth between sort of what the lead investigative team is thinking and what the local site is thinking, but I think it's a bidirectional process all the way through. Also, from the perspective of the lead node, the lead site, and excuse me, I'm trying my nomenclature, lead investigative team, I'll say, the lead investigators and the local site is the organizational climate at the site. It's useful to think, is this the time to do this particular study? So a study that's a talk therapy study done at an outpatient treatment program that's based on a treatment that's being advocated for within that state or by the single state agencies is a different study than, as another example I've mentioned before, a placebo-controlled drug trial of a new medication. And where is your organization in terms of the interest and the enthusiasm and their willingness to take on a placebo-controlled trial as opposed to a psychosocial group therapy, for example. And that's something that the lead investigative team is going to be looking at and paying attention to as they go through the site selection process. But it behooves the local site to really think about that as well. And what are the factors or the barriers that might come into play? It doesn't mean that those are insurmountable, but it's better to know what they are so that you can plan and anticipate things. One thing that has come up that's also something to think about, both from the lead investigative side as well as the local site side, is where the site is in reference to the node resources. So, I call it the RRTC, the Regional Research and Training Center, but that may not be the same across different nodes, but sort of the academic institutional hub of the node. If it's 2 states away or 3 states away, both from the local site and the lead investigative site, you want to think, well, is that going to have an impact on the support that can be offered to that local site? And so it may not be insurmountable, but it's a question that's probably reasonable to ask. So, for example, in the case of my remote site for CTN 30, the prescription opioid study, we asked questions about how the node was going to support this site, given that there was a very significant travel distance between the local site and the academic medical center that they were affiliated with. So just something to think about. The other thing to think about on this, and we can go to the next slide, is current site obligations. And with this, I'm not just talking about other studies. I mean, obviously, if there are other activities going on in other research studies, that might be important to know. So, for example, a site that can do very well recruiting one study for cocaine abusers might have a difficulty doing 2 studies for cocaine abusers because they might be competing for the same population, and suddenly the pool to draw from is much lower. But I wouldn't just say that. I think that it's an overall commitment. So if there's just been a big change in leadership, or they're overhauling and about to have a big set of meetings related to strategic planning and the mission, or they've just had a downsizing in staff and their resources aren't there, or there are just other things that are going on. Locally here, for example, I have a site that's about to have a big move of their facility. Well, it's something to think about in terms of, is this study going to put them over the edge in terms of how much capacity and commitments that they have? And it's something to pay attention to as the lead investigative team as well. And I sort of jumped the gun a little bit on the next slide and talked already about institutional support, so I'll go fairly quickly through this. But again, I can't emphasize enough how important it is to know that the local site has the support that they need from their organization. Many of our sites are small, and the person who's very involved in the CTN is also the person that's running the whole show. But there are other sites that are in larger organizations where it's not necessarily the case that everyone there knows about the CTN and understands the implications of what it's going to be like to have a CTN study. And make no mistake, there's a lot of really good things about being involved in the CTN, But there are also some things that many of us already know, I don't need to tell you, that make it tough. Running a study is tough. There are a lot of rules. There's a lot of oversight. The funding reimbursement doesn't always come on time as much as we might like it to because of things that are out of everyone's control. It's just how the federal government operates, and it's just sort of the nature of the business is sometimes things don't come exactly on time. And it's better for the institution to know that in advance than to be caught off guard 3 months into a study and find out this isn't what they thought they'd signed up for. And so identifying the stakeholders within that institution can be critical. And that's not just from the lead side, that's from the local site side. If you really want to do a study as an investigator at your organization, figuring out who else needs to know to make sure that it's okay, and not just know you're doing a study, but really what the implications of that are. And there are a lot of people you can talk to about that. So we're going to get into some more cookbook things about the ways that we can do things, but I wanted to give you 2 examples, and there's much more detail about this in that paper that I referred to that you can get, and it's online with a click. But this is an example of some thematic or content areas that we covered in 2 studies in the CTN. So the first was Dr. Donovan's stage 12 study, and Dennis, who was a co-author on that paper, very kindly worked on providing this piece of this. And then Roger Weiss and I and a lot of other folks were involved in the prescription opiate study. And so these aren't our actual questionnaires, but what we did was we did come up with site selection questionnaires, and I think that these are some of the early examples of how we did site selection. So I won't go through all of this because it's a lot of detail, but you can see in the differences between the questions, some of them might be more or less to your preference, but they were really guided by the trial design. But having done that and not having talked to each other about how we designed our surveys, you can see that there's some overarching areas. So on this first slide, site program and policy, trying to anticipate upcoming changes, trying to understand a little bit more about the site so we could get a snapshot. And this was all part of our structured site selection process that we asked people, or required them actually, to complete in order to be a potential candidate site. And then we used the information to evaluate our slate of candidate sites. So on the next slide, we had study participant population, and you can see I hone on that a lot because of this of posts. But you can see in this that stage 12 did the same thing. They wanted to understand a lot of things about population. In the post-trial, we actually asked people to collect more data, and I think I saw Patsy on here. So Patsy Novo, if you don't mind that I'm giving you as an example, I think she actually was the one who ended up down in a clinic trying to get this information about opiate abusers one time because somebody had to collect it, and Patsy very graciously was there to do it. And if I'm wrong on that, I apologize. But we asked very specific questions because we had such a very defined, narrow group of participants that we wanted. We were genuinely concerned whether we could find these people. And as it turned out, there were slews of these people at many of our sites, and so we were very fortunate in that way. But we actually embedded in the survey very specific questions that were our eligibility criteria. So if you went and looked at our protocol, you would see that there's an eligibility criteria related to 5 or more days of heroin use in the last 30 days, which would in fact have excluded someone from CTN 30. And we couldn't get that without having people collect that information. And then another thematic area on the last part of this slide, and then we'll hand it off, is, next slide, Liz, is the facility. We asked less questions about facility than the stage 12, but you can see in the stage 12 survey, they really took this a step further and really, I think, did an excellent job of trying to understand the nuances of this about the resources and capacity at the potential sites. So I'm going to hand this off to Shauna again, but I think we were supposed to pause and say if there were any questions or comments that people wanted to throw in at this point. They were supposed to be doing *1, is that right?
Yes, Jen. If anybody has any questions or comments, they can press *1 at any time, and we'll take their call. All right, do I hand things over to you, Shauna?
Yes.
We do have a question, actually, from Mary Mitchell. Please go ahead.
Hi, Mary Ellen.
Mary, your line is now open.
Thanks. Hi, Jennifer and Roshana. I think Jennifer's most recent point about the eligibility criteria for the trial being very, very important as defining the study population that's available at the site. And the more the site can know about the types of patients that the trial will be entering, the better off everyone is. Thanks.
Yeah, I can't thank you, Mary Ellen. I can't emphasize that enough. And in fact, when we just recently, I'm now on the other side of things, and I was working with our local VA here to be a site for CURB, and we fortunately were selected. But one of the things we did was, it was not required, but I was so convinced by the process in the POTS trial that was useful, that we actually went in, and the VA has very good data, obviously, but we went in and did some polls of data using the eligibility criteria that we knew for CURB to really try and slice the numbers and see to what extent we had those folks within the population. And even though the VA hospital is very large and they have a lot of substance abusers, when you actually start slicing the population down, you can see the margins get a lot smaller in terms of how many people you can get. So even if a site isn't an investigator isn't asking or requiring that, I really think that it behooves the local sites to do some of that work in the ways that they can. It doesn't have to be perfect. It doesn't have to be as rigorous as sort of a published study, but I think the more you can try and hash those numbers apart, the better.
Okay. So, hello everyone. We keep talking about the site selection process. And to point out, where exactly does the site selection process occur in the pre-implementation phase? And when we say pre-implementation, this is before the trial is launched, before any studies are endorsed. This is more the preparatory phase, getting all our ducks in a row phase. So as you can see, site selection occurs pretty early. If there is a delay or if there's a lag, you can see that impacts the rest of the pre-implementation phase, we'll call it here. And you can think of this as a chain of events. So I'll go on to the next slide. So things that could cause a kink in that chain of events is when, the site would have to be really honest with itself, and when it fills out a selection survey. And you want to be able to really realistically look at your capabilities as far as your IRB timelines. Are you submitting to more than one IRB? If so, do they have timelines that that can fit together, or do they contradict? Staffing. Most times the staff required for the protocol are not necessarily available at the time of the site selection survey. I think it's important to let the lead team know as much as possible your institution's requisition process. How long do you think it is going to take to get the appropriate staff? Your facilities. We can't drive this point home enough. As far as the points of the needs of the protocol, can your facility fulfill those needs? And your local regulations, understanding your DEA regulations, make sure you bring a point to that to your lead team if they are dealing with a Schedule III medication or any dispensing of medications. And the only thing I really want to just kind of like harp home here is the importance of being transparent, explaining. It doesn't necessarily mean that you're going to be whittled out or excluded, but I think the more upfront and transparent and honest you are about your abilities, it gives the lead team a chance to really weigh you, and I think that would give them more chance to understand what you're working with. So in regards to the site selection process and the lead team, and I've had a privilege of being on the lead team of several few protocols where, and I just wanted to talk about the dynamics or the makeup of the lead team. Usually you have your project director, a NIDA CPC or clinical protocol coordinator, a CCC representative in the form of a protocol specialist, and the CCC is the clinical coordinating center. You have your DSC representatives, your data and statistics center representatives, and your lead node personnel. The lead node personnel are pretty much the group that are the author and come up with the site selection criteria for the survey. Once they have their site selected, they must submit a site selection plan to the CTN for what information belongs in the site selection plan, as well as guidelines on how to fulfill that. Please see the current CTN policies and procedure guide located in the TPR page. You also, for this plan, you should summarize your site requirements and the preparation of the site selection survey Once that's prepared, it's usually distributed to your CTN node coordinators. The CTN node coordinators then forward that selection survey onto potential site candidates that they feel would be a good candidate or a good fit for the protocol. Once the site personnel has completed the survey, they submit that to the lead team for consideration. So one thing, when you have your site selection survey, I like to think of it as an opportunity for reflection and to see if you can verify your fit with this protocol. One thing you should do or consider doing is you should search your database logs or admittance logs for your population that you have gotten that has been admitted to your CTP or research site. Also, when you get this population, understand the screen fail ratios for the study. Lead teams do provide this ratio as far as what they feel could be the screen fail ratio. When you have your demographics at your site, as well as these screen fail ratios, you should be able to do a cross comparison to understand what your potential site enrollment facts are. Also, you should understand or be familiar with other studies at your institution that may compete with the inclusion-exclusion criteria of the protocol.
Shauna, could you talk, this is Jennifer, could you talk a little bit more what you mean by screen fail ratio?
Sure.
Or an example of that and how that might play out?
Sure, and Mary Ellen kind of posed a question to Liz and I earlier. So, for example, if you're in an opiate study and you have 900, CTP has 900 patients enrolled that fit the description, just because they're opiate abusers, do they meet the age criteria? Do they meet the are they taking other medications? All those kinds of things. What ends up happening is you may have somebody that fits the bill, but they may have an inclusion-exclusion criteria that they don't fit. They become a screen fail. So even though you might have 900 people, at the end of the day, maybe 100 people, when you get the inclusion-exclusion criteria, actually fit. So your inclusion-exclusion criteria, if you would like to think of it as a funnel, that is the best kind of analogy I could come up with. And that basically, that ratio is what determines your screen fail ratio.
And I would also just add to that, if it's all right, that then, so if we take that number, we can even narrow it farther. So let's take it with 1,000. Like 1,000 people are potential, well, that seems high. Let's do it 100. So there are 100 potential people that you know exist in your population right now in real time that might be candidates for this study, or that have opioid dependence. And then of those, you take it down, and then you've got 30 that actually might meet the eligibility criteria after you slice it all these different ways. Now, among those 30, how many are actually interested in doing your study?
Exactly.
And so then it gets even smaller. So suddenly, the 30 subjects that you needed to recruit, and you thought, well, I have 100 people, that's not a problem, although that I would always be concerned about that ratio, but that's 30, that's not, so getting 30 from 100 isn't a problem. Then suddenly it becomes even more of a problem because that assumes that 100% of those people want to do it. And so my rule of thumb that I tend to use is 80-20. For every 10 people that for every 100 people that you think you have, 80 of them are not even a possibility, and so you go down to 20. And so that's the way I think of it. So you need a lot more people than we tend to think until we actually start to do the numbers on this.
Thank you, Jen. That is perfect. Thank you. So also, looking at the protocol, do you have experience with the treatment model or the therapeutic intervention? Your experience with the lead node or the investigator, was it good or bad? Your previous experience. Are the follow-up visits reasonable? For example, studies require long-term follow-up. We have studies that have 3 years, 5 years follow-up. While that's just a follow-up period, you have to also account for the database procedure, the database cleaning that occurs after a study has closed. So you have to allow for maybe 6 months to a year for that process. So are you capable of committing yourself to a 3-4 year plus period? It's important to really think about that. Also, are the procedures in the protocol, do they go against your CTP's goal or mission as far as what standard of care they may offer? That may impact if you would want to even be a part of the study. In addition, some protocol procedures may cause you to decrease your billing capability of a participant. For example, for the CTN 44 study, they asked sites to allow for participants to miss 2 hours of group to do the TES intervention, or the Therapeutic Education System, which was their web-based intervention. So doing, they would have to decrease their ability to bill for that time. So that was just an example of this point here. And these are things you should really consider when filling out a survey. Also, looking at your population requirements. As Jen alluded to earlier, while you might have a population that's great now and it has a great trend, your trends could change. Also, because you heavily recruited for this one particular group, may not be able to do so for this protocol. So it's important to understand that and also address any population shifts or drifts. This could impact your protocol performance. Your staff requirements. For example, do you need ancillary staff members? How will this impact, if you do need them, how long will it take for you to acquire them, to train them? Is there adequate support for your PI? This is more important for studies that are very complex, that have a very, very large assessment burden, are complex in nature. They require a lot of support for the PI. They require a lot of sub-investigators. Do you have that support? How can you get that support? Do you know of individuals that are capable of supporting your protocol at your study? Do you have the substantial amount of staff needed to conduct the study? I find that this particular point, if you explain your requisition process, if you don't, and things like that, I think it allows for you to be able to explain this to the lead team. Circling back to that transparency point, it's very important to be transparent about your staffing abilities as well as your staffing capabilities. Your facility. Do you have the adequate office space, clinic space? For example, monitoring, consenting. If we require you to get an accessory piece of equipment like an EKG machine, is this possible? Some studies now do direct data entry. That being said, they require wireless internet. Do you have the IT capability for like a tablet study or a direct data entry study? Supplies. We will be sending you supplies. The lead node sends supplies. Do you have space for these supplies? And another question that's not asked, and it's usually, I find this question happens at the investigator meeting, but I think it should happen before. What supplies are needed at the CTP? What do you have to supply for this study? For example, we're doing a urinary drug screen. You have to supply your own gloves. I think these types of questions should be asked from the site to the team at the conference call that I'll talk about in a second. So once we get the lead team gets the completed surveys from the site, I like to call this the American Idol, finding the select sites that fit for your protocol. There's elimination round. First we get the surveys back. Surveys that are missing crucial information are eliminated. The next set of surveys, the lead team will schedule a conference call. During that conference call, we're just trying to see the fit. Would you fit with the protocol? After that, there's also assaying or examining of the site's capabilities to perform the protocol functions. And that's usually determined at the qualification visit, where the lead investigator and probably a project director will go out to the site and walk through, and I'll talk about that next. At the qualification visit, all the lead team wants to make sure that they can determine your ability to conduct the research in the study. They will want to verify that you have the adequate staff. If not, that would be a perfect talking point to talk about your requisition process, how you know what staff you want, and all those types of things, training, education, and experience and resources. And it's really important to demonstrate enthusiasm. I think a lot of times I always look at the qualification visit as a job interview. If you have a very enthusiastic candidate, you'll give them a shot. and I think it's important to display that enthusiasm. The agenda, rudimentary agenda for a qualification visit is there's a facility tour where you would tour the facilities if there's a pharmacy or things like that they're asking you for, or you would tour that. You would meet with the site staff if available, or meet with the ones that are available. You would review any outstanding tasks or discuss them. Those would be the transparent points I hinted at, as well as have a Q&A section. So these are all important parts of that facility tour, and I'd say take advantage of it. Pick the lead team's brain as much as they pick yours. And also, I just wanted to pause and say, are there any questions? If there are, please press the *1 feature.
Oh, we have a question from Alan Cohen. Please go ahead.
Hi there.
Hi, Al.
Hi, Jen. Nice job so far. Just one comment that I was thinking about some time ago, and this relates to when we're doing the site questionnaires and the phone calls. There's a lot of emphasis, of course, put on populations, as you and Ro have talked about. I find over the years that there are some questions that are not traditionally asked in this way, but that can help expand a little bit more on the description of potential participants and the pool from which you're going to recruit. And one of those questions, I think, is not just how many opiate-dependent patients have you seen in the last, or admitted in the last 6 months, but there's also a question that's useful when you ask, why do you think you'll be able to be successful in recruiting in this study? It's an opportunity for the site to talk to you about, well, we haven't admitted a lot of buprenorphine patients here, but we have, hundreds, if not more, who would jump at the chance if we had a research protocol to support it. So I think that sometimes we need to use those numbers and be judicious. The other thing is, I hope you'll probably get to it, is the role of subjectivity in selection rather than, in addition to objectivity. So when the lead team has whittled the list down to 15 good sites that they are considering, how do you make those final decisions? Where do you make? Where do you draw the lines? And so that was my comment. Thank you.
Thanks, Al.
Al, I completely agree with both of your comments. I love that question, actually, because I think if you only look at the numbers without the story behind them, you might miss really good sites. And I think that that's important, particularly if the sites numbers are low, because it's not a complete package. And I don't think these things really are they're all related, and so it's hard to just pull one out without thinking about the other factors. And just, I know we're getting close on time, but just real quickly, I think this is my personal opinion, and I have not been involved at the lead site level on a blinded site selection, but my feeling is it's really hard to be objective about this, and we have to recognize a certain subjectivity to it, and I think everyone needs to recognize that there is a subjective component to it, and that might mean it's not always fair, and sometimes that's helpful and sometimes it's not. I'm not sure that we have empirically demonstrated the best way to do this. We have some ideas and some assumptions, but not so, for what it's worth.
Thanks, Al, for your question. I think it's a great segue for discussion of blinded site selection. And this is totally optional. The CCC can provide the blinding for you. Once you get the site selection surveys, they're completed, we blind them, basically taking away the node affiliation, PI affiliation, and just looking at the numbers and the facts of the site selection. And as I said, eliminating these the accessory information, you really look at the hardcore facts. It provides anonymity to the site, as well as puts them on a level playing field with well-known sites. And it makes you take a second look at a site that may not, because they weren't affiliated with a certain node or a certain PI, you give them a second look because you don't know that information. And it's also an effective method of objective site selection, as Al had mentioned earlier. So thank you for your question. Awesome. Yeah, this is Jen.
Oh, it's me now? Oh, sorry. So just a couple things about that I alluded to earlier that I just wanted to pop out in terms of strategies. I'm a big believer in trying to pull the existing data, and again, I'm going back to that old site population thing, but using national epidemiologic and local data to inform evaluating both sites locally and then nationally where we might want to target. And so, for example, again, I'm just using posts as an example, but in that study, we actually pulled multiple data sets from the criminal justice data and from the DAWN Drug Abuse Warning Network data and all of these things, and we actually laid them out on a map. And on the map, we had put all of the nodes and all of the sites in the CTN, and then we independently pulled all the hot spots for where we thought the prescription drug abuse problem was. And some of this is unique to that particular issue at the time. And then we looked and saw that many of the areas that were hot spots were actually areas that we had a CTN, or at least we had a node in, if not a site. And that really helped us to guide the process. And as it turned out, we looked retrospectively back, and the sites that were able to get those recruitment numbers most easily and really were able to pull the numbers in without as much of a demand burden were actually the sites that on our little red map had turned out to be there. And so that just for our own informal little experiment did that. But the other thing that I mentioned this already is there's lots of ways that you can get data both from your internal data at a specific site, because as we move towards more and more electronic medical records, there's just a wealth of data as appropriate with your local requirements and regulatory that you can pull out. And the other thing is a lot of national data sets that are published by the federal government, you can actually go in and ask that organization to pull that data for your area. So again, when we were looking at a cocaine study in San Antonio, the first thing I did was I contacted SAMHSA, and I said they publish it by the state and county level, but I wanted to look at it a little more narrowly. And when I called the Substance Abuse and Mental Health Services Administration, lo and behold, one of their folks answered the phone, and I said, I'm really just looking for a few zip codes. How small can you take it down so that I can understand how many people are looking for cocaine treatment that don't actually get it, and how many people have cocaine according to your survey? And they were able to do that, and they'll tell you that it's not statistically there's issues with the statistics when you get down that level, but at the same time, I got to see exactly what was going on in my area based on this methodology. And if anyone's interested in that ever, for any reason, I can tell you how I did that, but it's really a pretty cool thing, and there's lots of ways you can get that data, so I think that that's really important. And then the other thing is, I think I've covered that, is the idea of collecting prospective data, which we've already talked about. Shauna, we can keep going through this.
Okay, so first, I want to talk about the recommendations of the site selection process. And as far as for the site perspective, you want to stand out. You want to complete the site selection surveys, be as transparent as possible, have the appropriate staffing capacity, and if not, be capable to explain and understand your requisition process. Any pending policy changes that could be happening or occurring at your site that you have wind of, please let the lead team know about those. You want to convey enthusiasm and be able to demonstrate that you can handle the task of the protocol. And you also want to be upfront about any current participation in trials that compete with the eligibility criteria. And these include CTN and non-CTN studies, as far as having the appropriate licenses and registrations to do the study as well. So I think this slide is pretty much like a good sum-up slide of a stellar type of site or a stellar site. You want to be aligned with the study mission and the outcomes. You want to have cost reduction, or better yet, cost protection measures as far as having a risk management plan, meeting your deadlines, meeting regulations, meeting your requirements, able to show that you can conduct the study with quality as well as its processes. And as well, again, I want to further emphasize this, adhering to the timeline, because when the timeline is compromised in any way, it's time and it's money. And also for the site staff, I can't harp on this enough, enthusiasm. The node staff, institution enthused and engaged about the study, I feel like that is a direct tie-in to the participant being enthusiastic and engaged in the study as well. And Jen, if you have anything you wanted to add to this, or, you know, if I said it all, said the piece, then fine, but
sounds good.
Okay. Are there any questions from the audience at this time? If there are any questions, you can push star 1 at this time. So what I'd also like to bring to everybody's attention is the CTN Dissemination Library by tomorrow, we'll probably have a recorded version of this presentation, as well as the article that Jen was referencing earlier. The training information is available under the training section under CTN Training. You scroll down and you can get one of their webinar recordings and download the PowerPoint presentation as well. And you could just do a quick, simple search and you can find the article that Jen has been referring to all along. If there's no questions at this time, this concludes the webinar. Again, Dr. Sharpe Potter and Dr. Rothwell for joining us today. It's been a pleasure working with you, and it was a really great presentation. I want to bring everybody's attention to our next webinar. It's the second part of the social media webinar. It's going to be held on February 29th at 1 p.m. Eastern Time, and it's going to help people get started with social media. So a little hand-holding and getting into this new world for many people. Thanks very much, everyone. Have a great afternoon, and we will see you at the next webinar.
Thank you, everyone. Bye.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.